Morning. Thanks for having me present this work. So my study was a evaluation of an educational intervention that we've been part of at our institution since 2014. I don't have any disclosures to make. The only thing I will say is I did this project as part of a master's degree in clinical epidemiology. The aim of our study was to assess the impact of the colonoscopy skills improvement program on colonoscopy quality for surgeons in particular at our institution. So the colonoscopy skills improvement program is one of a few programs that falls under a larger umbrella of the skills enhancement for endoscopy program. This was actually created by the Canadian Association of Gastroenterology. So the other two programs, they have a trained endoscopy trainer, and there's also a polypectomy course. But specifically, the program we looked at, the colonoscopy skills improvement program, it's a one-day hands-on course. The focus is on providing performance-enhancing feedback to endoscopists, and specifically they cover topics like room setup, scope handling, torque steering, patient positioning and repositioning during the procedure as you're inserting the scope, insufflation technique, like using water rather than air on the way in, loop recognition, and reduction. So the course itself, it's a one-day, like I said, it's a one-day intervention. You actually the endoscopist does a procedure, is monitored, gets feedback during, and then you talk about it again after. And there's time for discussion for anything else that they want to talk about. So my study in particular, we did a retrospective cohort study. The primary outcome we looked at was adenoma detection rate. We also looked at some secondary outcomes, which were cecal intubation rate, withdrawal time, and then sedation, dosing and usage. So we included 9 endoscopists in the study, so all general surgeons. It's worth noting that 6 of the 9 had over 5 years in practice, so it was an experienced group. We sampled 50 procedures before the training, after the training, and then we took another 50 for each endoscopist 8 months kind of after the training to look for any long-term effects. The colonoscopies were a combination of both screening, surveillance exams, and diagnostic exams. So we included essentially everything except for the FIT positive procedures, just because the FIT positives, we know for sure, have higher ADR. So there's a total of 1,350 procedures included in the study. Most of them were screening or surveillance exams, so it's 60%. We compared the patient groups at the different time points, and they were similar in terms of patient age, gender, ASA score, procedure indications, as well as bowel preparation adequacy. So adenoma detection rate improved immediately after training, just slightly, and then at the 8-month mark, it was significantly improved when compared to the baseline time point. So this test was done, this was a univariate analysis using chi-squared test. And then in the multivariate logistic regression model for ADR, the 8-month time point after training was associated with higher ADR. And other variables were also associated with ADR, which we'd expect, like age, patient age, gender, and then indication for procedure. So sedation dosing decreased significantly immediately after training, and then went down just a little further at the 8-month time point for both fentanyl and Versed or midazolam, which are the only 2 sedation agents we use at our institution. These charts on the left shows the mean doses of fentanyl per procedure, and the right shows mean doses of Versed per procedure. So we used ANOVA for this. This was our univariate analysis here as well. In our multivariate linear regression model for fentanyl dose, so both time points following training were associated with lower fentanyl dosing. Other variables which were associated with fentanyl dose were patient age, patient gender, and procedure indication. And so the same was true for Versed dosing as well. So there were no significant changes in the remainder of the quality outcomes. of note, cecal intubation rate was 95% at baseline, so it was high quality endoscopy, and it didn't change significantly. And withdrawal time also was above the minimum standard for quality and did not change significantly. So just some conclusions and discussion from our study. So CSI training may improve ADR for surgeons. We did see the trend towards improvement immediately after training, and then at that 8-month time point, we saw a significant difference. This is not a novel idea though, because there was a study in 2014 by Kaminsky and all done out of Poland, which was a randomized trial with a similar type intervention, which showed improvement in ADR with their educational intervention. This is the first study, however, to show a reduction in sedation dosing following an educational intervention. So the possible explanation for the change we've observed is likely better overall technique. It's also worth mentioning that the course kind of highlights repositioning the patients as you insert the scope to get it in with with greater ease. So to reposition the patient, it's easier to have them a little less sedated so they can move themselves rather than having the nurse and yourself try to physically move them. So that may partially explain the decrease we've seen in sedation. Our study had some limitations. It was a retrospective study. We had a very experienced group of endoscopists. So our baseline, ADR was 30.9%. The completion rate was 95%. So if we had a less experienced group, we might see more pronounced changes. That's it. I'd just like to thank my supervisors and multiple medical students I had helping with the project, and some funding we got from our local health authority. And take any questions.